started, we have equipped 10 chemo centers across the country with chemo drugs, with chemo chairs and all the equipment, so that people can be able, those who have been diagnosed to have cancer, will be able to access treatment at the periphery. Not going to Kenyatta, not going to MTRH, Moi Teaching and Referral Hospital. That we are already doing. But of course, under our cancer prevention and control strategy, we also going to have 4 cancer centers of excellence, so 4 hospitals. At the moment now, we've already started. Of course, Kenyatta and MTRH are working now, but we are putting 4 more others, which are going to be in Mombasa, which are going to be in Nakuru, which is going to be in Nyeri and Kisii. And of course, we have added another one in Garissa. We've already started the exercise. Hopefully, by the end of the year, we are going to have 1 functional cancer hospital additional to Kenyatta and MTRH.
Such grand plans in the fight against cancer in the country. That's a big story. This evening, we're having this conversation with Dr. Mercy Korir, who's in studio with me. We're also speaking to Banbella Ahura, who's a senior nursing officer at the Cancer Treatment Center at the Kenyatta National Hospital. Ladies and gentlemen, thank you so much for joining us on the big story. Dr. Mercy, let me begin with you. We've already had from the oncologist who gives a grim picture of cancer in the country. But there's something unique that was launched today at Aga Khan University Hospital here in Nairobi. I want you to tell me a little bit about it, and there's a reason why I want that in this show.
Okay, well, this is a story that we'll be obviously doing later at KTN News, but at the Aga Khan University Hospital, they've set up a PET CT scan. This is one of the major things that have been taking many Kenyans to India and other foreign countries. So this is a very specialized scan that uses radioactive material to detect the cancer cells in whatever parts of the body that they may be. So this is what we've been doing, and the Aga Khan Hospital actually established it this year, and they've started offering services. So this is a very costly investment, and from discussing with them, they told me that this cost at least $6.5 million US. That's about 650 million Kenya shillings. This is a private hospital making that investment, and what inspired them, or what actually drove the Aga Khan Hospital to do this, was the very large numbers of Kenyans that are going out of this country to India, to South Africa, to the UK, very many places. And we know even notable people that have been going abroad just to seek this kind of care, PET CT scan, or this kind of radiology examination, just to determine, one, where their cancer is and the extent of the cancer, whether it has metastasized to other parts of the body or whether it's confined, so that it can advise the management or the further management of that particular patient, or even just see how effective the treatment that they are on is ongoing. So they've done this, and the good news is for many Kenyans is that they have partnered, or rather NHIF, the National Hospital Insurance Fund, is covering for the cost for everyone who is eligible for this PET CT scan. Of note here is that not everyone diagnosed with cancer or suspected to have cancer is eligible for this PET CT scan. So the doctors at the Aga Khan will go through a really thorough assessment to see who is eligible or who would benefit from having a PET CT scan. And if they are under the NHIF, then at the Aga Khan they'll have this covered, obviously at a cost which the NHIF will cover. And I thought this was really a positive progress for the country. But again, this for me would have been much better if it was coming from the government, because this still means that many Kenyans will still have to travel to Nairobi to access these services. If we had it across different areas of this country, then it would be of more benefit. And as we've had the DMS there have been many plans, and I'm sure this is what we'll continue discussing in this big story, Linda.
Yeah, because Mercy, I mean, this is Aga Khan University Hospital is in Nairobi. There are millions of Kenyans out there who may not be able to even find their way to Nairobi. Mr. Ahura, talk to me about the experience you've had from Kenyans, the Wanjikus out there who may want to get some of this help, the treatment, cancer treatment. They're unable to, the ones who come to public hospitals. Dr. Mercy, you're talking about Aga Khan University Hospital. That's a private hospital, though we understand that NHIF will be able to cater for the costs. But what about the ones who come to public hospitals like Kenyatta? Talk to me about the experience. What's the most difficult part of this for them?
Okay, thank you so much for having me here to talk about this burden that's so
overwhelming on our country. The scourge of cancer, I can say it's like when you used to say that HIV is either you are affected or you are infected. So right now we can also compare cancer to that period where we were with HIV/AIDS. In Kenyatta National Hospital, most of the patients, they normally come for treatment, but mostly they normally come at a very late stage, simply because before MTRH came into place to managing cancer conditions, KNH was the only institution managing cancer patients in the country, public institution that is. And it is so far the only institution that's having a radiotherapy machine in the country, in the public institution. So the burden has been so much in that, I can say in my department, like in the Cancer Treatment Center, per year, we normally see like almost close to 6,000 new cancer cases every year. So that burden is so much because also the workload, the staffs, is overwhelming.
I need you to talk to me about the experience that cancer patients go through. So then maybe we can pass this message across so that whoever it is that's responsible or in charge of this can make quick decisions, because there are millions of Kenyans out there suffering. So when a Kenyan comes to Kenyatta National Hospital, what are some of the challenges they face in the quest to seek medical care?
They have diverse challenges. Some of them being, most of them they come from very far across the country. You can imagine somebody coming as far as Turkana. Then also having in mind that the cancer, this person is suffering from cancer. So there's that aspect of somebody having the fatigue, the patient is very ill, then traveling all that distance. Us just in our own state of being healthy, traveling makes us to be tired. So you can imagine somebody is very sick, having cancer, for example, is in stage 4, very sick patient traveling all the way from Kisumu, coming all the way to Nairobi, or traveling all the way from Mombasa or Hola, coming to Nairobi just to seek that treatment of cancer. So it's so challenging to them. Then another thing about the cost. The cost of treating this cancer is so overwhelming to our patients. You find most of them, before NHIF came on board to cover these cancer ailments, they used to pay cash. So, and you find in our country whereby somebody is living with less than $1 a day, it becomes a challenge when it comes now somebody diagnosed with cancer. So on the side of cost, also the distance, somebody covering all the long distance just to seek treatment here in Nairobi. Then also another thing is about a lack of specialized health workers on this field of oncology, of cancer. We have very few nurses who are trained on the side of oncology. We have very few doctors trained on the side of oncology, and many other faculties of radiotherapists who are trained on the side of oncology. So we find there are very few. So the ratio of patients to the healthcare worker is so big. You find maybe one nurse treating over 80 patients, or one doctor managing over same number of 80 patients, which is so overwhelming to the healthcare workers, especially at the Kenyatta National Hospital. So maybe the part the government can play is to train more health workers and sensitize more health workers on this surge, so that at least can relieve that burden from our institution. So pumping more funds into the training and equipping of more health institutions.
Tell me, when you say some of these patients before NHIF used to come in, they would pay cash, how much are we looking at?
It depends now with the type of treatment the patient has been put on. For example, if per session in radiotherapy in Kenyatta National Hospital goes at a cost of 3,600 per session, and maybe this patient is going to get around 25 sessions. So if you multiply that, it comes to almost like 50,000. And maybe for chemotherapy, it can range between 20,000 to even 100,000 or even 200,000 per session. And maybe this patient is supposed to have chemotherapy for around like 18 sessions. So very few patients can afford per session of between 100,000 Kenya shillings for 18 sessions.
Okay.
Because if maybe the doctor has prescribed, the regime the doctor has prescribed is going at 100,000 to 120,000. So you can imagine going through it for 1.5 years. It will be tiresome, and most of the patients, they'll give up in between, and thus stop the treatment.
Yeah, this is something that has crippled very many families. Dr. Mercy Korir, he's mentioned specialized health workers, lack of specialized health workers in some of these health facilities. And I know we had this conversation earlier in the morning, and you're telling me about the kind of training that Aga Khan University Hospital has invested in a doctor. Talk to me about the cost implications, how long it took, and whether or not, from where you sit, public hospitals can actually afford to do what Aga Khan has done.
Well, Linda, allow me to just go back, and I'll come back to the issue of cost on training, because this really impacts a lot on the patient experience. And I know my colleague there has elaborated on the patient experience, but I'd like to break it down to three parts, where there's a pre-diagnosis phase, where you find that so many people will go to hospital. Somebody will go that they have a dry cough that is not going away, or they have an upset tummy that they don't know what's about, or they are coughing and they don't know what's about. But in the lower health system, where most people will go because these symptoms really look mundane and minute, they are treated maybe for pain, for something minute, then they go home and they keep shuttling between the public hospitals, going round and round and never really getting diagnosed. And at a point where people are frustrated now, they go to a higher level facility where now probably some form of more serious investigations, maybe an X-ray, a CT scan for those that have, or an ultrasound will be done, and that's when the diagnosis is made. Remember, at this time, somebody has wasted a lot of time, for some people even 5-10 years before that diagnosis is made. You can imagine the kind of anguish and trauma that somebody goes before that. Then you can't make a diagnosis at a point where it's late. And as Dr. Odhiambo had said, most of the people that get diagnosed in our country, diagnosed at late stage, stage 3, stage 4, when they have metastases. I know I've had an experience where somebody just came with back pain, and then when we did an X-ray, they lit up to show that this person actually had a prostate cancer that had metastasized, and the first time we diagnosed was because he had back pain. This means he probably had had symptoms that were diagnosed or that were probably treated as something else and not the right thing. And now after the diagnosis is made, Linda, most people really struggle to come to terms with this. So here you're thinking about counseling services. So do we have the right counselors to give this kind of information? And even the doctors that will make this diagnosis, are they the correct kind of doctors? Remember that doing a CT scan or an X-ray does not necessarily confirm that it's cancer. You need a pathologist. So you really need a whole working laboratory to support these other services so that you can make the diagnosis and say this is this type of cancer, and in areas where it's more advanced, you can even go down to the molecular level and be able to advise the oncology team that this is how you probably treat this kind of cancer. And this is not just the doctors. You have, when you talk about a laboratory, you are talking about all the technicians, all the biomedical engineers that you need for that department. The same to the radiology department, not just the doctors, because we keep on talking about the capacity and we dwell on the doctors, but you're also looking at the laboratory technicians and the biomedical engineers that will be needed. So basically, radiographers, there's a whole team behind that will need to make that diagnosis and then go to the treatment. And then when you go to the treatment, it's not just the doctors, there's a whole team from nurses to the counseling psychologists and everyone else that is needed, even those people that the patients, even the janitors in the wards. Some of these people actually, by talking to these patients, can actually comfort them when they are going through this phase. After the diagnosis, you're talking about aftercare. If it's stage 3 and 4, do we have capacity for palliative care services? Do we have hospices that will attend to the care of these patients? You're talking about making their end of life quality. Are you managing their pain? Are they feeding well? Are they sleeping well? They're all these things. So do we have the capacity to do that? So when we talk about building capacity, it's not just the doctors. So when you look at the investment, like where I was this morning at Aga Khan, they took 3 of their radiologists to further specialize in nuclear in this nuclear medicine, and they took them to Geneva, to London, and one other country that I keep forgetting, so that they could specialize, and they spent a whole year just studying this particular set of skills. And not just the radiologists, they are the radiographers and the nuclear pharmacists who will support that particular department. Now, when you have set up that department for PET-CT, after you've made your diagnosis or you're monitoring, there's a whole oncology team that needs the advice of these people or the radiology department so that they can manage the patient. So when we talk about cancer and look at cancer, it's a holistic discussion, but we sort of tend to really just talk about the cost, and it's a high cost of care, but we never really look at a whole holistic and a whole 360 view from the pre-diagnosis to even the post-care for somebody who will just benefit from palliative or hospice care.
Mercy, wow, okay. That's a whole list, eh? That's a whole list of individuals involved in this. Ahura, if you can hear me and if you listen into Dr. Mercy Korir, from what she has explained, what is needed, the ideal, what do we have as from your experience at Kenyatta National Hospital? Are we halfway? Are we quarter way? Are we nowhere near that ideal situation?
From my experience, I think we are not that halfway, but not even near. We are still very far because one, about the training of the healthcare workers, that the nurses, the doctors, the whole team, the whole team in oncology, we still have a shortage of healthcare workers who are trained or specialized on oncology field. There are still very few. Like in the whole country, I can say there are like only less than 30 nurses who are trained on oncology.
Wait. In the entire Republic of Kenya, you have 30 nurses trained in oncology. 30.
Those who are trained, 30. Less than 30. Around
less
that
than
figure.
30 for a population of 40 million plus.
Exactly. So you see, we are still not yet there. So there is more need for, there is that urgent need to train more healthcare workers, more nurses, more doctors on this field, more clinical officers on this field of oncology, and also sensitizing more healthcare workers down in the grassroots levels, so that we can detect this cancer at a very, very early stage. Because most of them, just as the way Dr. Odhiambo had said, if we detected them at a very early stage, they are curable. But most of the healthcare workers, they have not been trained or sensitized on cancer cases. That's why you have most of them coming at a very late stage. Thus, this burden being so huge, that's overwhelming this public institution like Kenyatta National Hospital and MTRH. Yeah.
Apart from capacity building, in terms of the need to train our clinical officers, our nurses, our doctors, our technicians in the field of cancer. When we had the Director of Medical Services saying they are setting up cancer centers, then the immediate question that comes to my mind is, are they just doing brick and mortar? Or is there a plan to actually make sure that there is the right human resource to offer this cancer care? Because if you have a building and you have equipped it and there's no one to operate, then of what benefit is it? We've seen it from the managed equipment services, where we were told that, they provide CT scan, a mammogram, and now we'll be able to detect cancers. But in actual sense, what we had were this equipment without the right personnel to operate them. So we have them lying idle and not offering any services. And in fact, these ones are not really offering the cancer services that they were sold to us as offering. The other thing I've seen is that there was a whole 7 billion budgeted for CT scans. And the other narrative that has been sold to us is that this will help in fighting cancer, because yes, cancer is a menace. But the question I ask is, well, CT scan is just one of those modalities that will probably tell you that there is a growth here and you need to do something about it. So is there a supporting laboratory for it? Is there a supporting team? Because, Linda, if one is diagnosed with cancer today, the next question that obviously comes to mind is, what next?
What next?
Is there treatment? Is there hope for me? Is there something you can do for me? So there's no point for me as a doctor to tell you that, you have cancer of the breast, and this is the management, yet there's no team that will take you through that management process, from offering the chemotherapy, from offering the radiotherapy where it's needed, or even the surgical care that is needed. So we have to look at it from a whole point of this. So my question to government is, when we are saying we are establishing these cancer centers, when we are saying we are providing these CT scans and we've put aside a budget to purchase this, is there an attendant budget for the human resource and the whole capacity to manage that whole cancer, because it's not just about treatment. As we've seen, there's a whole thing from prevention to even palliative care.
So Mercy, what you're saying is you can't have one without the other.
You can't. It needs to be holistic. Linda, one of the questions, and you have been, or rather maybe you have gone to hospital with a patient, if the doctor tells you that we have found that you have a broken limb, the next question you ask the doctor is, okay, so what do we do about it?
Yeah.
Do we fix a plaster? Do we go to theater and fix it in theater? What do we do about it? So it's the same thing for cancer. If we have diagnosed, there's no point of making the diagnosis if you're not going to go through the whole system of care. And for this...
There's no point of making that diagnosis then sending someone to India.
Exactly.
To go and spend 6 point whatever million.
So what we need to do immediately as a country is we need to really sort out our health system. As we've seen, people go round and round, and that's one of the reasons why we get late diagnosis, because the capacity to have that index of suspicion that it could be cancer is lacking. And then even when we make that diagnosis, offering that proper care, there's long queues everywhere. Even at the Aga Khan, where they now have a PET CT, because of the demand, they have long queues. So we really need to work on our system so that people in Turkana can have their holistic cancer care in Turkana, and they don't even have to even travel to Moi Teaching and Referral Hospital for that care. Every pocket of this country should have a whole system that works, and that's all the way from our level 1 facilities to our level 6 facilities. That's the referral hospitals. And we've seen countries where the Ministry of Health has been saying it's been benchmarking on. That's Cuba and Thailand. These people have worked on their health systems so that it's well tiered and it responds to the needs of their people. And if truly the country is, or the government is benchmarking from countries like Thailand, and we've done these stories, then it should be easy for them to implement. Two, they should have learned by now that these countries invested in their human resource fast and heavily, so that these people can then use the other brick and mortar and all the other equipment that was part of the investment to offer care to their people. And this is what we really need to dwell on as a country, instead of just looking at brick and mortar investment or tangible investment that really at the end of the day will lie idle or not have anyone using for the benefit of the people of Kenya.
Mercy, okay, we need a whole show, like maybe 3 hours to do this with you. Mr. Hura, so you get to have the final word. If from your observation, from your experience at Kenyatta National Hospital, something, I know there are plans, and Mercy says, they're sort of half-baked. You know, you need a holistic approach to this. So from your experience at Kenyatta National Hospital, what should the country be doing now to ease that pain for cancer patients, now, short term, as we look at long term?
First, I would say train more healthcare workers, that is from all the clinicians in this field of cancer. Then sensitize more community health workers right down in the grassroots on this issue of cancer, so that we can detect it at a very early stage and be able to cure it. Then second thing is maybe I can say put more funds that's on training and also on research on this cancer in our country, not to be depending on some information from the Western countries to which they normally give to us. We can also be doing our own research here in our country on cancer.
To it, yes.
Yeah. Then another thing, cut down the cost. Maybe the government can come in and cut down the cost of treatment of this cancer, because the cost is so high that most of our Kenyans cannot afford. That's the high mortality rate in cancer cases. So the cost of treatment, the cost of the radiotherapy, the screening, it should also at least come down to a point whereby most Kenyans can afford. Then also the insurance cover, the NHIF, you find that most patients, after going through treatment, there's a time they reach a level where the NHIF will say, you have exhausted your cover. So this patient has again to go back to their pockets and pay. And as we know, we are living in a place whereby poverty levels are very high. So it's very hard and very tough for the patient, for the care worker, because you can imagine you are treating a patient, you have gone almost half of the treatment, then the next day this patient does not appear because of maybe lack of finances. So it's also somehow it also disheartens you or breaks your morale, because you'll see this patient, you lose this patient just because of just some few coins.
Hold on, Mercy, are there limits on NHIF coverage of this?
Sorry, Linda, let me quickly add on to the issue of cost. And sorry, I didn't hear your question, but you'll just...
Limits, NHIF limits. He says that's the problem.
Yes, and I actually want to address that on the issue of cost.
You have a minute, Mercy.
Yes. Healthcare is expensive. Cancer care is even more expensive. Remember a while back that the former vice president of the US, Joe Biden's son, succumbed to cancer, and he actually acknowledged that it was actually quite expensive to manage cancer. So that's a first world. What is it to a third world country? In my opinion, and I usually say this is a very pedestrian question that I ask, why is NHIF trying to make a profit? This is public funds that should go out and help the public to cater for their care. If it's going to cover cancer, there's no point of having a limit, and when it's exhausted and probably somebody was almost getting healed, then you have to pull them out of treatment, or they fall out of treatment, as my colleague has said. The public fund, which is NHIF, should cover cancer holistically, all the way through for everyone. There's no point of somebody starting care only to drop off halfway because they couldn't afford it, or because NHIF could not cover it because it can only do, let's say, 500,000 or something like that.
Right.
You should go the whole hog because this is a public fund.
Great, Mercy. That's a perfect point to leave this conversation this evening on The Big Story. Thank you so much for your time. A big thank you to Dr. Mercy Korir. I told her this is a conversation. We need an entire show, 5 or 6 hours, just to talk about this and get to the bottom of it. Mercy Korir, thank you so much for your time. Banbella Ahura, Senior Nursing Officer, Cancer Treatment Center, Kenyatta National Hospital. And a big thank you as well to Dr. Andrew Odhiambo, oncologist, who spoke to the lead reporter, Sophia Wanuna. This has been The Big Story. Have a good evening. I'm Linda Ogutu.